This conference will.
Mask is obviously a joke. Good evening, everyone. I'm Joseph. I'm a paediatric registrar at Barnet Hospital. And I and Dr. Harween Dogra are here this evening to talk to you a little bit about gastroenterological presentations to the ED for general paediatricians, also known as gastro-emergencies. I didn't want to call it gastro-emergencies because it's not all gastro-emergencies. It's just some gastro-emergencies that I think it would be good to be aware of. Comment. And hello, Harween. So what's coming up? And I guess why is this relevant? What's coming up is we're going to talk about some cases. We've got 3 cases that we're going to discuss, and we're going to discuss learning points. It's really as simple as that. Why is this relevant? So last I checked, Crohn's disease has adults and children has a prevalence of 157 per 100,000 in the UK, and a third of those cases are diagnosed before the age of 21. So in a paediatrics world where we are starting to see more and more adolescents, and those are coalescing into one, it's really relevant from that point of view. And UC has an even higher prevalence of 240 per 100,000. And the peak incidence of UC is between the age of 15 to 25 years. So again, those teenage and adolescent years. Also, I think it's really important to treat IBD properly. I'm talking mainly about IBD, as in why that's relevant, because it has unique sequelae different to IBD in adults in terms of the growth and development of children and adolescents. So all very relevant stuff. Let's crack on with case 1. So case 1, abdominal pain in ED. You're the paediatric reg, or you're the paediatric doctor in ED, and a child comes in with abdominal pain. They don't actually come to you because they're already referred to someone else. But they're a 16-year-old girl with abdominal pain. Does anyone want to comment on what sort of questions you might want to ask in terms of history taking? All right, we'll move on. So in terms of history taking, we want to know how long it's lasted, where it is, what kind of pain it is. So this pain is all over the girl's abdomen, although now it's more in the right iliac fossa. She's not been eating and drinking as much recently. Alice K asked a very important question: is this pregnancy? Harween asked a very good question: where is the pain? Are there any other associated symptoms? Her parents are worried in terms of associated symptoms that she's lost a lot of weight recently and she's not interested in seeing her friends as much anymore. She's isolated herself for non-COVID reasons. Associated with the pain, she's had 7 days of diarrhea, loose stools with no blood, and she had some fevers at the beginning of this. And she saw the GP last week because of that, and they diagnosed her with viral gastroenteritis, and discharged her with safety netting advice, and so she's very sensibly followed that safety netting advice because it hasn't recovered, and she's come into ED. She has no travel or infectious contact history. In terms of past medical history and background, none. Previously fit and well. Now, I mentioned before that she has been referred to someone else. She wasn't directly referred to the paediatric team, and obviously she has been referred to the surgeons because she has abdominal pain, which is localized to the right iliac fossa, and so she's been admitted for a grumbling appendix, which I'm sure is not actually a thing, but query appendicitis. And of course, the surgeons very politely have requested via the nurses that the paediatric team do the bloods and write up the fluids because they're not sure how to do the calculations. So you very kindly, very dutifully decide to agree and do the bloods and write up the fluids and antibiotics for the patient. And when you're doing the bloods, you notice that the patient is very gaunt looking, very thin, quite pale, and this concerns you. And again, because you're a good paediatrician and you're always thinking with your paediatrics hat on, you decide while you're doing your bloods to do a heads assessment. Who does heads assessments? You don't have to answer this, but who does heads assessments regularly on adolescents and teenagers? We should all be doing them, because this is what comes out in your heads assessment. Home-wise, she lives at home with her mother, and her mother herself is in and out of hospital with her own abdominal issues, but she doesn't go into much more detail than that. Education-wise, she's in school, but she's barely been there over the last few weeks to month. She just hasn't had the energy to go into school, and she's been hampered by her abdominal pain. Activities-wise, she used to be really sociable. She used to have a very active social life, but that has tapered off quite some bit, and she barely sees her friends now. She used to have quite an active sporting life and play netball, but she can't do that anymore. Now she prefers to just stay at home alone and play video games. She smokes approximately 10 cigarettes a day. She denies any illicit drug use. She denies drinking excessive amounts of alcohol, maybe a little bit here and there at a party. She doesn't have any current sexual partners, but she's very comfortable with the idea of consent. She knows when to say no means no. And she hasn't had any thoughts or attempts of self-harm or suicide. So now that you've done that excellent heads assessment, does anyone have any ideas of potential differential diagnoses for this teenager? So let's see. Saskia, IBD, very on the ball. It's a potential, yes, but that's not what the admitting team, the surgeons, necessarily thought. ML, oncological, not a bad idea. Daniel Dexter, very good idea, pregnancy. Harween, really good idea, ectopic pregnancy. Alice Kate, anemia, yes, she's pale, she's gaunt, she's thin. Absolutely. The admitting team thought it could be, hold on, an eating disorder, absolutely. And so the differentials that were laid out were query eating disorder. Is this actually just an appendicitis that it hasn't gone away? Is it tubo-ovarian pathology and a referral has gone to the gynae team for that? Is it a UTI? No one was as on the ball as Saskia at that point and considered IBD. And the plan that was made was to do bloods, a normal full set of bloods, FBC, normal set of biochemistry, to do an MSU and send it off for an MCNS, to send stool for virology and microbiology, ovocysts and parasite, and to get an ultrasound, because we always ultrasound the young girls when they might have appendicitis. And the results. So the bloods showed a microcytic anemia with high platelet and what a lot of people would term a stonking CRP. Think of it between 75 and 100. And she also incidentally had a bit of a low albumin. An ultrasound abdomen was performed, which obviously couldn't find the appendix because they never can, and it also showed some thickening of the distal small bowel. Her MSU was negative and her stool samples showed no organisms, but she still got pain. We're now a few days down the line and she still has pain and she still doesn't want to eat. And so she gets referred to the CAM team for disordered eating. But you're working with Saskia, and Saskia said, actually, I think maybe we should speak to the gastro team about this, because there's something a bit fishy about this. She's got high platelets, she's got high CRP, she's got low albumin, she's a bit anemic, she's got this thickening of the terminal ileum. And so you discuss it with the tertiary gastroenterology reg at the centre near you. They listen so kindly and patiently and intently to your thorough and relevant history. And they ask a few more questions. And in the questions, they ask you elicit the information that her mother's health issues are all Crohn's disease related. Her mother has Crohn's disease. And they also have asked if anyone sent a CRP, an ESR, and someone has, and it's come back raised at 55. And they advise you to send stool for a fecal calprotectin, which is a marker of inflammation in the gut, and H. pylori antigen, because that's another cause of abdominal pain. All very good questions, Melanie and Claire. They also advise you to send bloods for tissue transglutaminase and for TFTs, because those could both be causes of this. They also advise you to send bloods for something called thiopurine methyltransferase before the patient gets any transfusions. And that's going to be really, really important. And I'll explain why. They also ask you to send bloods for a quantiferon to test for TB and to get a chest X-ray. And that is also going to become important because if the patient does have IBD and they end up having treatment for IBD, that could reactivate tuberculosis. And they ask you to obtain MRI small bowel to look for any stricturing disease in the small bowel, and to get regular electrolytes because this child has lost a lot of weight in a relatively short amount of time and has not been eating, and so she is at very high risk of refeeding syndrome. So what happens next? She gets referred to the gastro team because of your excellent referral, and she undergoes an OGD and ileocolonoscopy with histology, and that confirms Crohn's disease. She started on what I think is genuinely magic. She started on a treatment called exclusive enteral nutrition, which is basically milkshake. It's milkshake, and that's all they eat for 6 to 8 weeks, and that makes their gut heal. It sounds crazy, and it's amazing, and it's got as good success rates in terms of mucosal healing and treating IBD and treating Crohn's as corticosteroids, but with absolutely none of the side effects. Other drugs that can be used, other treatment modalities that can be used to induce remission are corticosteroids, as I mentioned. They come with all the well-known side effects, and anti-TNF alpha monoclonal antibodies like infliximab. There are also treatments used to maintain remission, like thiopurines, such as azathioprine or 6-mercaptopurine, which some of you may know from paediatric oncology. Methotrexate can also be used, and drugs like infliximab or Humira can also be used, as I mentioned, in the anti-TNF alpha monoclonal antibody class. Sometimes patients will need surgery, and that emergency surgery would be needed for complicated or toxic megacolon, which we'll have a look at a bit later. And surgery may also be needed later on or earlier down the line for isolated or localized disease which doesn't respond to conventional therapy, or complications like strictures or fistulae. Thank you, Holly, for answering the questions. The GastroReg also asks you to complete something called a PCDAI. Now, this is something that at the time you have to look up because it's got loads of different questions and parameters, and they're laboratory based and they're examination based, but it's something that can help you stratify the patients with IBD into severity categories. So, and you've got it scores below 12.5 means they're in remission, and above 57.5 means they've got severe disease activity. We don't have to talk through this in detail, but it's something to be aware of, because it's I think the great thing about scoring systems is they remind you what you need to ask in your history and what kind of bloods and stuff you need to do. So abdominal pain, how badly it affects their life, how well they're functioning, how many stools they have, what their bloods are like in terms of their ESR and their albumin, what their examination is like, if they've lost weight, if they have fistulae, and if they've got fevers. So this girl would have scored quite highly because she has a great number of these parameters in the higher scoring ranges. So learning points of this case are: please don't dismiss weight loss and reduced eating and activity levels in teenagers as disordered eating, first off. There are lots of organic causes to rule out first, not only IBD, but also, you know, the basic stuff we discussed, like tuber ovarian pathology and UTIs, but also celiac disease, Helicobacter pylori, but also be mindful of possible IBD. It's really important to take a full gastroenterology family history in suspected IBD patients, or with people, with children or teenagers who come in with recurrent abdominal problems. And not to forget that we work in general paediatrics a lot, and a proper social history from a teenager, like a heads assessment, can elicit really important clinical information that can guide diagnosis and therefore guide treatment. So, on to the next case. More abdominal pain in ED, except this time it's a 15-year-old male who's come in with abdominal pain, and he has known ulcerative colitis. So the questions we're going to ask is very similar. How long has the pain been going on for? Where is the pain? What kind of pain is it? Any associated symptoms? How bad is it? What's his stool frequency like? So he's been having the pain for the last 5 to 6 days, and the pain is across his abdomen. It's so bad that he can't ignore it. It's waking him up at night. He also has bloody diarrhea associated with it, and there's blood in most of his stool. So most of the stool itself is blood, and all of the stools he passes have got blood in them. And he opens his bowels 7 times every 24 hours. Okay? He hasn't got any travel history and no infectious contacts. So, going to his past medical history, he has known ulcerative colitis. And the questions you want to ask a patient with known ulcerative colitis are, you want to ask about the distribution of their disease. You want to ask about how often and how many colonoscopies they've had, how many times they've needed steroids in the last year, if they've had any previous operations, and what their regular medications are. So he was diagnosed when he was age 9 years old. His distribution is pancolitis, so his entire colon is affected, and distribution can range from right-sided, left-sided, rectal sparing, or pancolitis, or more. He's had multiple previous colonoscopies. He can't remember how many he's had. He's needed steroids 4 times in the last year. He's not ever had an operation before, and he takes regular mesalazine and azathioprine. On examination, on general inspection, he looks pale, he's fed up, he doesn't want to be there, and he's quite slim and not particularly tall for his age. No cardiovascular or respiratory findings, except he's a little bit tachycardic. On his abdominal examination, you find tenderness and percussion tenderness at the left lower quadrant. He has got bowel sounds, and he has no palpable masses. So, what are the differential diagnoses? Anyone want to pop some in the chat? Nice one, Saskia. Need to rule out toxic megacolon. Rachel, acute flare, possible toxic megacolon, flare, infective or otherwise. Loving the comments, thank you very much. Infection, exacerbation, gastroenteritis. Yeah, all very valid. So, is it acute severe colitis, aka an ulcerative colitis flare? Is it acute infective diarrhea? Is it COVID? Well, I absolutely hope not. And what investigations would you do? So bloods-wise, you'd send everything you'd think to send: an FBC, UNEs, CRP, LFTs, bone profile, magnesium, an ESR. Microbiology-wise, stool for virology, MCNS, oversystem parasite. Anything else microbiology-wise anyone can think of, which is really important in IBD patients? Daniel Dexter, C. diff, straight in there. No messing about. Yes, C. difficile. And it's really important to check for C. diff in patients with IBD, because they're at increased risk of getting it. And if you do have it, it needs treatment. Blood cultures, if you think they have systemic sepsis. And imaging-wise, we want an abdominal X-ray. And clues as to why you would get an abdominal X-ray are they have left lower quadrant tenderness, and they've got severe disease. And how do you know they've got severe disease? That's the question. You know they've got severe disease because you're an absolute pro and you've done a PUCI. And a PUCI is a really easy, it's quite different to the PCDAI that we discussed before. The PCDAI is, oh, are we recording? recording in process. Good. The PCDAI has got blood parameters, it's got examination parameters, and the PUCI is so much easier because it's 6 questions that are all questions. It's a questionnaire that you ask the patient. You don't have to do examinations, you don't have to do bloods. And you get a score of 0 to 85. If you get score less than 10, you're in remission. If you score over 65, you've got severe disease. And the other scores are somewhere in between. If you've got severe disease, so a score over 65 or left lower quadrant tenderness, that qualifies you automatically for an abdominal X-ray to rule out toxic megacolon. And this is what the PUCI looks like. It's really simple. It's just, do they have pain? Can they ignore the pain? Can they not ignore the pain? Do they have rectal bleeding? Is it most of their stools? Is it not most of their stools? Is their stool complete water? Is it partially water? Is it formed? How many stools are they having per day? How many are they having waking them up at night? And what's their activity levels like? So you see, this is a really simple, really easy tool, which can be done on any patient with ulcerative colitis, and it should be done every day that they're having a flare to judge how they are, if they're improving, or if they're static, or if they're getting worse. This is toxic megacolon, which is what we discussed. And megacolon is in the name. The colon enlarges, and you can find the parameters online for different age groups and different sizes. But it's enlargement of the colon and edema of the bowel wall, and sometimes you can have rectal sparing. The plan for this child would be admit. They've got an acute severe colitic episode. You screen for GI infection. Once you're happy that that's clear, you start IV corticosteroids. So either methylprednisolone or hydrocortisone, depending on where you are and what their unit advises, and discuss early with the patient's gastro team. And this is a tip. If you are calling the patient's gastro team and their patient has come in with an acute severe colitis episode, and you turn around and say, oh, hi, I've got a child with known ulcerative colitis, they've come in and their PUCI score is X. From the off, they are impressed, you've got their attention, and they're listening because they know that they're talking to someone who is interested and knows what they're talking about. And these patients need daily PUCI scoring, as I mentioned, in order to judge which direction of travel they're taking. I've just got some questions here. Any reason on exogram rates IV? Not sure. While awaiting micro investigations which take time. Hoween has also already answered that. Thanks, Hoween. So daily PUCI scoring for these patients, right? In terms of ongoing management, what we're trying to achieve is maximum symptom control balanced against minimal side effects and mucosal healing. 5-ASAs like mesalazine are one of the main treatment, and mesalazine is preferable to sulfasalazine because sulfasalazine has side effects. The only downside is mesalazine isn't available in liquid form, so it can't be given to young children. Thiopurines are another mainstay of treatment, such as azathioprine or 6-mercaptopurine, but they have a lot of side effects. They have a lot of side effects like nausea, headaches, they do damage to your skin and hair, they give you an increased risk of pancreatitis. Anyone who's ever had pancreatitis can't have azathioprine, and there's a small increased risk of lymphoid malignancies. And the reason I mentioned earlier that TPMT, thiopurine methyltransferase genotyping, is so important is that if someone can't metabolize a thiopurine and you give it to them, the side effects of that are worse than the IBD itself. The other fantastic thing about thiopurines is that we have something called 6-TGN level monitoring. And 6-TGN level monitoring allows us to essentially see whether or not the patient has been taking their medications. It allows us to see whether or not the patient is toxic. So it's a really good longer to medium term drug monitoring tool. Similarly to Crohn's, you can use anti-TNF monoclonal antibodies like infliximab or adalimumab. Adalimumab isn't licensed in children, and there are newer agents out there in addition to those two. And really important for ongoing management of these children and young adults is nutrition and growth monitoring. As on an ongoing basis, but also as an acute flare, you want to make sure that you're on top of their nutrition. And if they do present with toxic megacolon and they are heading for acute surgery, you want to consider parenteral nutrition early. As with Crohn's, surgery is an option. Surgery can remove bits of colon, can remove the entire colon, but that's not really where it ends. And children and young adults who have a total colectomy then are committed to a stoma for a minimum of 6 months. And even then, if they do have a pouch formed, that has its own side effects and complications. Why was he so unwell? Why was he so unwell? He was so unwell, as we discussed, because you're a really good pediatrician, you do a heads assessment. Sorry. And you do a heads assessment and you send off a 6-TGN level, and it's low because he hasn't sadly been taking his azathioprine because of all the reasons we mentioned. So as I said, you did another heads assessment and you find out that his IBD team had recommended him to take enemas, which he has declined. He isn't taking his azathioprine. He has needed multiple steroid courses, so he's got poorly controlled IBD. Just wanted to go over a few comparisons or differences between Crohn's colitis and something called IBDU, which used to be called indeterminate colitis, but is now called inflammatory bowel disease unclassified. So Crohn's affects the entire gastrointestinal tract from the mouth to the anus, whereas UC only affects the colon. IBDU only affects the colon, and it looks histologically not clear between Crohn's or ulcerative colitis. That's why it's indeterminate. Crohn's disease has skip lesions, it's transmural, and most importantly has granulomas. If there are granulomas on the histology, it's Crohn's disease. Whereas ulcerative colitis shows continuous disease and is confined to the mucosa. Crohn's, as I mentioned, can be treated with exclusive enteral nutrition, the magic milkshake, whereas sadly ulcerative colitis is unaffected by diet. IBDU's treatment is similar to ulcerative colitis because it's confined to the colon. Crohn's is worsened by smoking, which is why it was so imperative that that 16-year-old girl in the first case stopped smoking. Ulcerative colitis is improved by smoking. That is not an indication to tell people to smoke, obviously. And in Crohn's, you get stricturing more commonly, whereas in UC, you less commonly get stricturing. So our learning points from that case are: do a PUCI. You don't even have to remember the score, you can Google it, but do a PUCI because it's validated, it's non-invasive, it's easy, it's quick, it's even only 6 questions, and it's part of the history that we're going to be asking anyway. And when you're calling that gastro-reg, call them with that PUCI because it's a really good tool for assessing children in real time. Every patient with acute severe colitis, when I say acute severe, I mean PUCI over 65 or left lower quadrant tenderness, do not miss toxic megacolon, just do the abdominal X-ray. And send stool microbiology and virology before starting treatment. And if they have C. diff, treat it, please. So here's some learning, some resources. So these are 2 really great papers. They're kind of like British Society of Paediatric Gastroenterology, Hepatology and Nutrition, IBD working group papers, which are both open access. And they are basically just how to do IBD, and they're excellent. I really, really recommend having a look at those if you've ever got a question. And on to the next case. You're the peds reg, you're in ED, and a febrile toddler walks in. Hooray! That's pretty much the only thing that walks in winter, but a febrile toddler has walked in. It's a 2-year-old, and they've come in with a fever. History of presenting complaint. They spiked a fever up to 39 degrees centigrade this evening. They're well, but they've got a bit of a snotty nose, no respiratory symptoms, they're not recessing, no abdominal breathing, nothing like that. They've had a vomit, but that's not unusual for them. They're a bit vomity anyway. And their stool consistency, all you'd know is normal for them. With this information, before you walk into the cubicle and get anything else, what would you do? Daniel Dexter wants a weight plot. Anyone else? Just with this information, what would you do? You've got a 2-year-old with fever, PPE, very good. Check obs, better history of the stool, examine. But generally speaking, 2-year-olds who come in with fever, what normally happens to them if they're well and they've got a bit of a snotty nose? Absolutely, Claire. If it wasn't gastroenterology, why are they here? Well, you go in and you find a bit more about their past medical history out, and they're on home PN, short bowel syndrome. They've got a Hickman line in situ for their PN. I know that we've written PN. We haven't written TPN because it's very rarely total. Okay, almost always children have something enteral. They have a gastrostomy in situ for their peg feeds. They're an extreme prem. They had necrotizing enterocolitis as a prem. They've got a bit of developmental delay, and they've been advised by their nutrition team to attend ED with any febrile illness. But you examine them, and they look really well. They're afebrile. They've got a normal examination. Their Hickman line side, their gastrostomy side look perfectly healthy and fine. And I guess the question is, again, what are the differentials and what would you do? Claire Miller on the ball, straight to it with line sepsis. The Claires are on fire. Yes, you worry about line sepsis, but really in a 2-year-old, the differential is normally without a line, viral illness, possible bacterial infection. But here we are worried about CVL sepsis. That's our main concern, and that's how we're going to treat them. What would you do, though, in terms of investigation, imaging, intervention, and would you admit them? Would you admit every one of them? Saskia, very sensible, could still be a virality, needs bloods, culture everything, I agree. Would you admit them? Above, admit septic screening, start antibiotics, admit Noella. Well, we agree. Bloods, central and peripheral blood cultures, a blood gas, an FBC, electrolytes including a bone profile and magnesium, they are after all on PN, and a CRP. A viral throat swab, because yeah, they do have virality symptoms, and we send stool samples for MCNS and virology, urine dip, MCNS, just to rule out other causes of fever. But would you admit them? They look so well, and their mum doesn't want to stay. They're not even tachycardic at this point, Claire. No. But sensible plans, admit for a while, admit. Always admit these patients. Admit these patients, screen for infection, as you've been saying. That's right. Claire Miller, line sepsis kills. And I guess the take-home point here is treat this like you would a child with possible febrile neutropenia. Admit them, screen for infection, start IV antibiotics early, stop their PN. It says consider, but actually stop their PN and start IV fluids. Consider line locks, antibiotic line locks, and discuss them early with their gastroenterology and nutrition team, because they might have an individualized antibiotic protocol. They might have tips for how to write up their IV fluids. And crucially, as I'm sure you would all do with all patients with a line, if they're having septic showers when using the line, stop using the line, because that line may be infected. Mum wants to leave because she wants to go home. They've been in with query line sepsis a number of times, and it's never actually line sepsis, and that's what she said. But we still treat as line sepsis. So the three mainstays of treatment here are fluid volume, stop their PN and enteral nutrition, start IV fluids, match their fluid volume to their total fluid intake, their total PN and enteral nutrition. Discuss with their tertiary team whether or not you can continue PN, because they might say that you can. Your ward staff might not be that happy about it in a DGH, but in some cases, if the parents are particularly competent, they might be allowed to put up the PN themselves, especially if they're very au fait with it. IV antibiotics, cover for line sepsis and gram-negative organisms. Some will say gram-negative organisms, on point. For example, tazocin and gentamicin, tazocin and vancomycin, but again, they might have an individualized regime of antibiotics, so check. Continue their enteral feeds unless they're systemically unwell or overtly septic. In terms of writing up their IV fluids, as I said, match the volume of their usual PN prescription. Try to match the composition of glucose, sodium, and potassium. Now, different places, different gastro teams will have different requirements. I know some in London want 10% glucose, some are happy with 5% glucose, some are happy with just 5% and 0.9% sodium chloride, with alternating bags of potassium. If you can't tailor the IV fluids and create designer fluids, it's safe to use 5% glucose and 0.9% sodium chloride with alternating bags of 20 millimoles per litre potassium chloride. There is a calculation for how to put in the sodium and the potassium, and it's like this. The additive that's normally in their PN in millimoles per kilogram times their weight divided by their total fluid intake in 24 hours in millilitres times the volume of fluid in the bag that you're going to prescribe. And this will all be online, so you can, I'm not going to spend too much time with that because you can look it up. Sorry, just looking at the comments. So what is a CLASB? Just a little bit of discussion on a CLASB. CLASB is, CLABSI, central line associated bloodstream infection. And CLABSI kills. It's the most common complication of long-term home PN, and it may result in the need for their line being removed. And this is really important because lots of line infections leads to loss of venous access, and loss of venous access is a criterion for intestinal transplant assessment. So this has really important real-life implications for these children and their lives. Multiple septic episodes also increases the risk of intestinal failure associated liver disease, which is the thing that kills children on long-term PN. And that is another criterion for intestinal transplant assessment. Poor line sepsis management increases the risk of these complications. And so it's really important to look after their lines in these patients. Discuss antibiotic or toral lock, which is another kind of antimicrobial lock, or ethanol line locks with the tertiary team if you do want to preserve that line. Okay. So learning points. Sepsis is the most common complication for patients on home PN, and it kills them. And it's associated with an increased risk of intestinal transplant requirement. Any fever should be treated as suspected sepsis. Treat them as you would neutropenic fever, irrespective of how well they look. And discuss early about antibiotic choice, about PN prescription, and about IV fluid composition. And that brings us to the end. So here are references for that last case. If anyone has any questions, please. Oh no, 1 minute, sorry. Go for it with the questions, but in the meantime, let me get up our quiz. We have a quiz. Oh, 1 minute, not that tab. Not that tab. This tab. Right. Can everyone go to menti.com and use that code 959467? Ooh, we've got one vote. Well done, everyone. Yes, everyone that's voted so far. Yeah, I mean, everyone who voted has got it right, that management to induce remission in pediatric Crohn's disease. Should I let more people vote? We're still going out more. First-line management to induce remission in pediatric Crohn's disease is exclusive enteral nutrition. It is just like magic. Give them milkshake and they get. Next question is, how do I go to the next question? What? Right, the next question is, which of these symptoms is not part of the PUCAI score? It's fever. Sorry for those who went with stool type and activity level. Fever is not part of the PUCAI score. That's part of the PCDAI score. And our next question is, which of the following is a criteria to assess for intestinal transplant? Is it? Oh, it's two of them. It's two of them. Ooh. So, oh, they're still, the votes are still going up. So, the answer was loss of vascular access and intestinal failure associated liver disease. Those are criteria to assess for intestinal transplant. So, thank you very much, everyone, for coming to this talk. I hope you've enjoyed it. Thank you very much to everyone who voted in the Mentimeter quiz afterwards. Remember those take-home points. PUCAI scoring in UC, discuss very early, and treat CLABSI as you would any neutropenic fever. Thank you, everyone.